Hello, my name is David Armstrong. I'm the Director of the Health Workforce Technical Assistance Center. And today's event is entitled Psychological Safety, Work Environment, and Burnout in Nurse Practitioners, a Mixed Method Study. I'd like to go ahead and introduce you to today's speaker. Today's speaker is Rosalind Lisser, and she's an Associate Clinical Professor at the University of California, San Francisco, and lead for Psychiatry and Addiction Treatment UCSF Women's HIV Program. Welcome, Rosalind.
Thank you, David. I appreciate that introduction. And welcome, everyone. Thank you so much for joining us today. Shall I go ahead and share my screen?
Go ahead. It's all yours.
All right. Thank you.
I'll jump in when we start the Q&A.
All right. Here we go. Sorry, let me get adjusted here. So again, thank you all for taking time out of your day to join us for my presentation, Psychological Safety, the Work Environment, and Burnout in Nurse Practitioners. This is a mixed method study and really is a culmination of my dissertation work, which was completed this June of this year at Vanderbilt University and in collaboration with my research team at UCSF, University of California, San Francisco. All right. So as mentioned, I'm going to be talking really about nurse practitioners today. Nurse practitioner care is defined by excellence in evidence-based practice and outcomes, and is associated with improving access to care, decreased morbidity and mortality, and cost savings. The American Medical College has projected a shortfall in the primary care physician workforce. And it's against this backdrop that we've seen a rapid expansion of the nurse practitioner workforce, with a projected 40% increase over the next decade. As the workforce has increased, so has burnout. In a 2019 national survey of nurse practitioners, it was found that 38% reported feeling burned out. That number rose to over 54% in 2021 during the COVID-19 pandemic. There has been little evidence of abatement of burnout in clinicians. A recent survey found that over 60% report feeling exhausted, overwhelmed, and having difficulty sleeping. This really illustrates a culture of burnout where less than 50% of nurse practitioners report feeling supported by their workplace or that their employer values their mental health. Prior studies have attributed nurse practitioner burnout to issues in the work environment associated with decreased quality and safety. I'd like to take a closer look at the nurse practitioner work environment. So nurse practitioners are uniquely situated in healthcare. As advanced practice nurses, their work environment is influenced by the practice environment, which is informed by structural policies at the federal, state, and organizational level. These policies influence scope of practice and inform their autonomy and agency at work. The healthcare work environment is complex and varied, and is defined by overlapping factors which involve tasks within a social context as well as organizational culture. These may vary depending on role and position in the organization. So the nurse practitioner work environment is also informed by organizational climate. And this includes structural factors such as policies, procedures, and organizational norms, as well as relational factors like interpersonal relationships, communication, and teamwork, all of which may promote or inhibit success. While these factors are not unique to nurse practitioners, they may be experienced differently depending on social status in a given organization. And this contributes to a culture of hierarchy, which is defined by power differentials between professional groups. So interpersonal relationships among healthcare teams are impacted by these power dynamics. So an individual in a perceived position of power may use their power to influence or direct the behavior of another, leading to growth and learning, or shut down and silencing. And here we find the importance of psychological safety. In the words of Amy Edmondson, an expert in organizational change, psychological safety is an interpersonal construct defined as the perception that the work environment is safe for interpersonal risk-taking. This is such as things like asking for help or reporting an error without fear of reprisal. This really contributes to a work culture where all voices matter. We know that psychological safety promotes growth, learning, and innovation in a rapidly changing environment and is linked to improved quality and safety and promotes a culture of safety. So considering that the nurse practitioner work environment is inherently hierarchical due to structural and relational factors in the practice environment, and with high rates of burnout nationally, I sought to understand nurse practitioner perceptions and experiences with psychological safety in the work environment and examine its effect on burnout. So to accomplish this, I conducted a secondary analysis of the 2022 survey of California nurse practitioners and nurse midwives and conducted interviews with a subset of those who answered the survey. To achieve this study, I consulted the literature on frameworks for understanding nurse practitioner burnout. And what I found was that most frameworks did not adequately address the social, organizational, and political structures that are germane to the nurse practitioner practice environment. Thus, I developed a framework, the social ecology of burnout. It is adapted from the social ecology of health promotion. It is multi-layered and presents interdependent factors relevant to nurse practitioner burnout at the intrapersonal, interpersonal, institutional, and policy levels. And this was the foundation for my deductive approach to the study design and analysis. The framework posits that the individual experience of burnout is really a symptom of the larger socio-environmental context of healthcare, where power structures have the opportunity to empower or oppress. So the study leveraged, again, the data of the 2022 California Workforce Survey. This survey came at a particularly important time and sought to assess the baseline of nurse practitioner workforce in California before the enactment of a piece of legislation called AB 890. Which went into effect in 2023. Yes, it took effect in 2023. This legislation creates a path toward independent practice for nurse practitioners in California. The 2022 survey included a random sample of 3,600 nurse practitioners stratified by geographic region to achieve a representative sample of the population of California nurse practitioners. But for this particular study that we're talking about today, I had, again, two samples. And for the quantitative sample, I drew from the larger study and included those participants who answered the survey and were currently employed in a position requiring nurse practitioner license, and they had to have completed at least 70% of the study measures. We had a total of 621 participants that met this criteria and were included in the analysis. For the qualitative study, the inclusion criteria included NPs who were licensed and working at least 20 hours. They had to have completed the web-based survey, not the paper-based, because that was going to take a very long time. So those who completed the web-based survey between July and October of 2022 were included. A total of 61 participants indicated interest in interview, and that was out of a total of 426 people who had answered the survey. So 61 were invited to interview in 2 rounds, and 17 agreed to interview and met inclusion criteria. So data were collected and analyzed in tandem and converged in this analysis. We assessed demographic and practice characteristics in the survey. A 24-item scale in the survey study we used a 24-item scale to measure perceptions of the nurse practitioner work environment, a 7-item psychological safety scale, and burnout was measured using 2 subscales, the 9-item emotional exhaustion and 7-item depersonalization scale. This analysis included descriptive statistics, correlations, and a mediation analysis to better understand the effect of psychological safety on the direct effects between 4 work environment factors on the 2 burnout factors. For the qualitative study, we used a semi-structured interview guide informed by the concepts in the social ecology of burnout. This included open-ended questions to really support storytelling and sharing of lived experience. Themes and associated quotes were generated using a qualitative descriptive analysis. So in terms of our results, you'll see here that the demographic characteristics were relatively similar between the survey sample and the qualitative sample. We had a larger percent of men in the qualitative study, and the mean age was slightly higher. However, there was ethnic diversity in both samples. In terms of practice characteristics, there were also similarities. And it is notable that while most of the nurse practitioners in our study had more than 10 years of experience, the median job tenure, the median number for job tenure was less than 5 years. We believe this is an area for future inquiry and monitoring and may be an effect of the pandemic. So in terms of my approach to this convergent analysis, it is of course informed by the social ecology of burnout, thinking about the interdependence among the study concepts, the bidirectional relationships, and really the nonlinear way in which these concepts show up in the work environment. The qualitative data was brought in to provide context, which was really core to understanding and illustrating what we were seeing in the survey data, and then exploring the divergence and convergence of that data. So I'm going to first start by presenting the descriptive statistics for burnout in our survey and interview samples. Here you'll see the median score of the survey sample for emotional exhaustion and depersonalization, suggestive of low levels of burnout in at least half of the survey sample. We also used the raw cutoff score for emotional exhaustion that's used in studies to identify levels of burnout. And you'll see here that 34% of those who were surveyed and 70% of those who were interviewed had a score of 27 or higher. This is suggestive of high burnout. While this is a really significant difference in our 2 samples, I will share that all participants who were interviewed had experienced burnout at some time in their career and spoke about relevant current and past challenges in the work environment. However, we did have 5 participants that had actively made changes at work to manage burnout, and we'll talk about what we found from that subset a little later. So in thinking about burnout, the theme "burnout is dread" really captures participants' descriptions of hopelessness, where you get to a point you feel like it's costing you your soul to go to work. Participants also expressed frustration, irritation, and a sense of dread. I wake wondering, do I really want to do this? Here you're seeing the descriptive statistics for the work environment scale. And this is the scale that we used was the Nurse Practitioner Primary Care Organizational Climate Questionnaire. We used median values for each scale, and I'm going to go over them briefly here. So practice visibility looks at the degree of role clarity within the organization. Independent practice and support looks at perception of autonomy and independence in clinical decision-making. Nurse practitioner administrative relations looks at perception that the nurse practitioner is valued by administration. And then NP physician relations looks at perception that physicians trust and value the NP as a practice colleague. So you'll note here that I have highlighted the median score of 3.3 for independent practice, suggestive that the upper half of our participants reported high levels of autonomy. Well, the first theme that I'll present here, the illusion of autonomy, really speaks to those on the lower half of our survey sample. Interviews began with nurse practitioners describing their work, responsibilities, and their team. They spoke of their day-to-day experiences, which were contextualized by description of structural factors in the work environment, and this included institutional regulations and scope of practice policies that supported or inhibited their workflows. So the illusion of autonomy describes the experience of those being hired into roles to provide care consistent with nurse practitioner training, only to find that their practice autonomy was narrowed or removed by institutional policy or physician preference. So in this quote, you'll see, "My scope is limited by the hospital administration. Our NP team doesn't write orders. I'm not allowed to prescribe at work. We have to reach out to a physician. Sometimes there's a delay in which physical safety is at risk for the patient and the staff." And this was a nurse practitioner who was part of a consult liaison team in an inpatient in a large hospital, but in a psychiatric consultation role. Here, this participant says, this last quote here is from one of 4 participants, all from different nonprofit academic centers across the state, who shared that their employers no longer permit nurse practitioners to carry independent caseloads. So one of them described this as part of their institution's care model transformation effort to manage physician burnout. So nurse practitioner participants described their autonomy being narrowed and their responsibilities being shifted into physician inbox coverage and overflow and caring for overflow clinic patients. And you'll really see in this quote, most of us don't really like this desktop work. It would be nice if I had my panel back. I mean, I've been an NP here for 20 years. So really speaking of this illusion of autonomy. So in this slide, I'll draw your attention to the descriptive statistics for nurse practitioner administrative relations, which is the lowest median value of all subscales, suggestive of lower or poorer relations. Our qualitative data gives some context to this. The theme hierarchy breeds dissatisfaction describes how participants shared their experiences of being belittled, ignored, pushed aside, and devalued by administrators and physicians. These experiences were described in the context of organizational policies perceived as unjust, inequitable, or oppressive. A participant working in an intensive care unit shared, "I treat the patient the way that I always would, but animosity grows. I feel like I'm constantly fighting to get all the stuff that I need. NPs are salaried, not hourly. We all stay late and physicians get paid for overtime. NPs don't." As well as this one, "When I was new and training on procedures, we would get bumped for residents and fellows to do their procedures first. They don't care. NPs don't get any time for learning at work." So it's this sense of working in an environment where they are less than or not as important. And hence we have this sense of hierarchy breeding dissatisfaction in the workplace. So here you'll see the median, the median score for psychological safety in our sample was 4.6. This is suggestive of fairly high levels of psychological safety. And when we look at the correlations between psychological safety and the work environment, it is positively associated with all factors. And you'll notice that nurse practitioner-physician relations is the strongest association. This makes sense as nurse practitioners and physicians often have very proximal relationships, working in teams or clinics together. Notably, the association was weaker with the nurse practitioner administrative relations. So after exploring the work environment, our interviews shifted into a deeper discussion of their clinical teams and interpersonal relationships. Psychological safety was explored by asking about speaking up behaviors associated with risk-taking. So all participants had stories that support the theme lacking psychological safety. While this diverges from those upper levels of the median, it does offer a window into those on the lower end of that scale. When discussing speaking up behaviors at work, such as asking for help or raising controversial topics, some nurse practitioners reported being unable to speak up and shared experiences of moral injury for not doing so. Others talked about fear of reprisal should they speak up. These experiences were described as a reason for resignation and or job change. In this last one, I felt torn. I had some concerns. There were plenty of red flags that the supervisors, were ignoring. I felt like, well, they're ignoring it. What am I going to report? I'm the newbie. This was a new primary care nurse practitioner sharing how she sat in silence after observing another nurse practitioner engaged in some questionable clinical practices. So both of these quotes illustrate the presence of silence behaviors at work. Specifically, this is quiescent silence. This is a type of silence that is due to fear of judgment or reprisal. We know from the work of Elad Scherf and others at UNC Chapel Hill that silence behaviors are strongly associated with burnout and carry a heavy cognitive burden. So we also found that psychological safety was negatively associated with both burnout factors. You know, embedded in the concept of psychological safety is the perception that one's voice is valued enough to speak up. So it makes sense, right, that in an environment where we feel psychologically safe, there's less burnout because we are more valued. Our qualitative data offers sort of a nuanced understanding of the intersection of psychological safety and those who are experiencing burnout. So participants were asked during the interviews to describe how their voice matters at work. The theme, No Voice, No Value, describes participants' experiences of speaking up, not feeling heard, and then feeling devalued. These were experiences that led to silence for many. So this participant shared, I don't think my voice matters. You will, just stop when you don't feel heard. This one also shared similarly, my voice doesn't matter. And honestly, I think that's burnout. I don't think a whole lot of what we do matters anymore. So these quotes illustrate the presence of silence. These quotes also illustrate the presence of silence behaviors at work, as we saw in the last slide. However, this form of silence is called acquiescent silence. This is defined as silence behaviors that are associated with loss of hope for change or loss of hope that one is going to be heard. So our participants spoke of silence. During the interviews, as the participants spoke of silence, and they largely associated that silence with feelings of concern for patient safety, self-doubt, and a sense of devaluation. The work of Michael Knoll at the University of Leipzig has found that these are classic indicators of fear arousal, which significantly contribute to a lack of psychological safety in the workplace. So while silence behaviors were predominantly discussed in the context of interactions with physicians and administrators, our participants really saw that as a threat to patient care. These behaviors really highlight the impact of how hierarchical structures and communication dynamics can lead to a sense of fear and mistrust in the workplace. So hierarchy and authoritarian leadership are known barriers to psychological safety and open communication. What was interesting for me during these interviews is that despite participants sharing that their voice may not have mattered at work, they also independently shared that they felt that their voice mattered to patients. One participant said, "I love the teaching I get to do with patients. I think that's where my voice is really heard." So patient care was seen as a protective factor for many. So when we looked at the intersection of work environment and burnout, we found that all factors in the work environment were inversely associated with emotional exhaustion and depersonalization during the correlation analysis. It is notable in both of these that nurse practitioner administrative relations is highest. I want to share two final themes that were generated that converge with this finding. Sorry, one final theme. Participant stories and experiences of their work environment were overwhelmingly characterized by emotions of anger, frustration, fear, worry, sadness, and discomfort. And the theme lost vocation sort of describes participants' shared sense of disillusionment with their chosen vocation. In this quote, you'll see, "You have the impression you're somewhere you don't belong," essentially. The sad part is no one really took what we NPs were offering seriously. I might not have the MD next to my name, but there's still value being provided. And here, "I don't feel appreciated. You're less than. I feel burnout, a sort of hopelessness. The politics and tiptoeing around having to cover everyone," that they were speaking to their physician team, "work in this sort of lesser mid-level kind of capacity. You have to be able to swallow your pride to be able to do this job." This quote really exemplifies the feeling of being devalued in role, and really captures participants' lived experience with the sense of lost vocation, which informed their experience with burnout. So finally, I want to share our mediation analysis. And this is where there's some positive news. After controlling for the practice setting, job tenure, and hours worked, the unmediated total effect of the 4 work environment factors with emotional exhaustion and depersonalization were all inverse. So you'll notice the mediating effect of psychological safety was strongest for the association between nurse practitioner physician relations and emotional exhaustion. You'll see the beta there of negative 0.10. The magnitude of that mediation effect represents a 37% reduction in the unmediated effect, which was negative 0.27. I've not shown that here, but I can show those tables to you if that's of interest during the question period. So considering the depersonalization subscale of burnout, the total unmediated effects of the work environment on depersonalization were smaller. So while the mediating effect of psychological safety was comparable to the effects observed for emotional exhaustion, the overall total effects were smaller. And so that proportional reduction is by psychological safety is greater. So that's why you see those higher percentages for depersonalization. Again, you'll notice the mediated direct effects of practice visibility. You'll notice that the mediated direct effects of practice visibility and nurse practitioner physician relations on depersonalization were no longer statistically significant. Yet, as the arrow suggests, it's notable that the smallest effects are seen with nurse practitioner administrative relations. So psychological safety doesn't seem to be affecting that relationship as much. Our results align with other studies that have found that clinician mistrust and lack of confidence in administrators is highly associated with burnout. And it may be due to the absence of psychological safety in those relationships. So how does the qualitative data come into that? Well, despite our mediation analysis, despite that sort of that piece about clinician mistrust, our mediation analysis does support our hypothesis that psychological safety is a protective factor against burnout. And as I mentioned earlier in my interviews, there were 5 nurse practitioners who reported no burnout at the time of interview. And this final theme, finding solution, really describes how they collectively spoke about advocating for autonomy and agency in practice management. And so it was in finding solution that this mediation where psychological safety, the ability to speak up, ask for what a person needs, feel heard, led to really a lower sense of burnout. So in the interviews, participants described their strategies to minimize or prevent burnout, which really centered on setting non-negotiable boundaries at work, protective of their well-being and their work-life balance. And this really included having control over their work hours, the number of patients that they saw in a day, and being invited into quality improvement efforts. So in this quote, the participant chose to actually narrow her scope of practice as a surgical first assist. And she did so on her terms. And you'll see there's a sort of defiance in her voice, which really captures the importance of autonomy and independence in practice. In this quote, a primary care nurse practitioner speaks of taking a risk at work and speaking up about concerns that had been contributing to burnout. She was speaking with her trusted supervisor. It was stressful to speak up about refilling the other supervising physician's patient opiate prescriptions because I didn't know what would happen once I set my boundaries. I wasn't going to stay at the clinic if they didn't agree. So there's sort of evidence in this quote of psychological safety and also confidence in her voice that confidence in the fact that if her voice was not heard, she was going to leave the job. And I think that in this particular situation, among others, was those that were not experiencing burnout, spoke up and their voice was valued at work and they were listened to and changes were made. So there was a sort of shared confidence in these 5 participants that they would leave their job if their expectations were not met. And it was supportive leadership that really supported them, right? And so this was, that sense of having a supportive leader was a common factor among those experiencing low burnout as they felt respected and supported in the workplace. So I think for this final sort of culminating piece, we see that psychological safety and speaking up at work is really core to promoting autonomy and agency and practice management, and ultimately supporting well-being in the workplace. So, whoops. Let's see. Sorry. My thing went a little rogue on me. All right, sorry about that. So that ends all of the results of the study. And I want to say that our study was not without limitations. So the cross-sectional design of the survey study really restricts any causal interpretations. There's also potential for non-response bias in the survey. As the parent study surveyed participants from 9 distinct regions in California. However, there's always risk that those findings may not be fully representative of the entire population of nurse practitioners in California. Additionally, this study was conducted in California, which is a geographic region where nurse practitioner practice is still restricted. This is, may limit generalizability of our findings to states in the US and other places where nurse practitioner practice is not restricted. For the qualitative arm of our study, the participants were recruited from those who completed the online survey, and they really self-selected to be interviewed. And so we did not recruit from the paper-based survey, so we may have been missing folks from that survey. Selection bias is also a big limitation here to our qualitative study. Our aim was to explore burnout in nurse practitioners, which may have really influenced those who chose to participate. So taking a social ecological approach to burnout, informed by structures of empowerment, I really view practice, policy, and education as sort of the way forward toward promoting both personal and professional success for nurse practitioners. I think you heard me talk about the role of power in this presentation, and power can be viewed as the ability and the opportunity for individuals to succeed in a given community. And so supporting learning systems who consciously adopt a culture of learning where power is given to empower, I think is incredibly important in how we support and nurture nurse practitioners in the work environment. And our study highlights that psychological safety may be an avenue for intervention at the individual, unit, and institutional level to support that empowerment. So system-wide interventions that seek to really adopt cultural values which promote psychological safety are also needed to support and sustain a culture of safety. Such interventions can build a just and equitable working environment, not only where all voices matter, but where all voices are valued. And I think this really speaks to creating a work environment where there's equity in well-being for all. So when I think about policies, I think that policies have the potential to drive change toward health system well-being. And such policies can prevent burnout and support worker well-being. And, I think our study really highlights a potential objective indicator, right, of success, which is psychological safety. Which is, psychological safety is specifically measured in most culture of safety surveys and includes questions about speaking up behaviors, silence behaviors, and perception of system administrator safety culture. So these measures can be used by health systems to track and manage outcomes. And again, I think can inform policy at the institutional, state, and federal levels. And finally, when I think about future research in health worker burnout, it is important to think about longitudinal methods to really track outcomes over time. And, since COVID, we've seen a real challenge with with high levels of burnout across the health professions. And so this longitudinal analysis and studies are really needed to better understand this phenomenon. So considering individual level metrics, I think that stress related to cognitive load and emotional exhaustion are potential for tracking stress biomarkers and other health-related outcomes as an objective measure of well-being at work could be considered. I think also longitudinal tracking of metrics, including psychological safety, speaking up behaviors, silence behaviors, engagement, and burnout, can shed light on how and when speaking up reduces burnout. This may also help expand our understanding of silence. So while our qualitative study identified hierarchy and devaluation of the nurse practitioner role as a driver of silence behaviors, more research is needed to understand how barriers to speaking up can be addressed to enhance psychological safety in the workplace. So I think that there's a lot we don't know about silence behaviors in the workplace, and I think there's a lot of research opportunities in that realm. So that concludes my presentation. However, I would like to just offer a few acknowledgments to my Vanderbilt advisor and committee chairs, as well as my colleagues at UCSF, specifically Joanne Spetz in the Institute for Health Policy. Thank you all so much, and I appreciate you joining.
Thank you, Roz. That was very informative. I really do appreciate the effort you made. I mean, you had two studies, qualitative and a quantitative one, and they had similar topics, but bringing them together in this mixed methods, presentation, I think it really enhanced it. I really do appreciate that effort. Seeing those two different methodologies together, I always appreciate that. So thank you very much. With that in mind, too, could you maybe talk a little bit more about how you recruited for your interviews and the reasons why you think they reported higher levels of burnout than, say, the quantitative study? What do you think's going on there?
Yeah. So the parent surveys went on for several months to enhance and improve recruitment of participants. And this was a dissertation, and so I was under some pressure to get done. So we really strategically chose to recruit participants from the online survey, and our really a large percentage of the online responses had already been received. So we recruited in 2 rounds. And that was to ensure that we did some extra strategic outreach to ensure that we had a representative sample of people across ages, diversity of setting, as well as diversity of licensure in the nurse practitioners who were interviewed. And so, but despite that, we all participants who agreed to interview on the survey were invited. And no one was turned away. We invited everyone, trust me. Why we had such high burn, I think there's a big difference there, right? It was predominantly a group who was experiencing high burnout. And I will say that during the interviews, folks, at the end, you ask that final question of, is there anything else you want to share? And people talked about sort of just the catharsis of being heard, which I really think, sort of gave me a window into perhaps why people who were actively feeling high levels of burnout wanted to talk about it, wanted to share. But that being said, those who were not experiencing burnout had mostly made recent changes. So, so everyone could really speak to the experience of each of the themes that were presented here.
Okay, thank you. And we do have a question. It's from Deborah Goldberg. Rosalind, very fascinating study, and I appreciate the quantitative and qualitative approach. I was surprised to hear how much communication played a role in feelings of burnout and moral injury. Do you have recommendations for addressing communication apprehension in training nurse practitioners and training for open communications across health professions?
That's a fantastic question, and thank you for that. I think that, communication is core to everything we do. And we know that I think that I don't have, well, I can actually say as a nurse practitioner educator, I think we spend a tiny little percent of time on teaching communication. And I know that's largely true for the other health professions. And yet communication is core to everything we do when we spend the smallest amount of time training on it. So I think there's a huge amount of work that can and should be done in communication training. And, there's been a lot of work from the VA, in communication training modules such as Team Steps and others, which, give you a really standardized and or objective format to follow. And those can be very helpful. I think what I really saw was two challenges that I think are places for us to enhance nurse practitioner education and training around communication. And I think this applies actually to all the health professions, right? Which is number one, confidence. What does it mean to speak with confidence, and how do I show confidence and self-advocacy at work, right? So what do we need to do to gain, to grow, to foster self-confidence and self-advocacy in the workplace? And I think that, in nurse practitioner education, that starts from day one, right? How we ask for things, how we engage with preceptors, how we present patients, all of those pieces are core and foundational. And this is, of course, very respectful communication that needs to be taught, and yet with a sense of confidence and self-assurance. And so that was one place I saw, wow, that's a place for what does it mean to have self-advocacy and in your communication. Then secondly is that this element of silence that kept showing up that really played into moral injury. And so, as I sort of talked about in the presentation, you've got people who were not speaking up because they were scared, right? They were scared they were going to be judged. They were scared they were going to be fired or some way put down. So there's a fear response. And there was another group that had been speaking up. I need a new computer. One person talked about asking for a laptop because they were being shifted from room to room. They were never being given a single room. And so could I just have a laptop so I don't have to keep signing in and out of computers? 2 years they'd been asking for a computer. And this was contributing to their burnout. Meanwhile, their more senior non-nurse practitioner colleagues in the clinic all got their own computers, right? So there's a sense of injustice in that. And so that comes when I've been speaking up and my voice isn't heard. And so I sit in silence. So this is really linked in with that sort of silent or quiet quitting. And so I think that's a much broader issue that gets at a larger challenge within our really our health professions workforce is what are the pressures that are leading to silence, and how can we address those? And I don't think that that's training for NPs or training for physicians. I think that really there needs to be interprofessional training around what does it mean when we silence one another, and what does it mean when we promote silence by not listening to one another and allowing folks to not only be heard, but also feel valued at work. So I hope that answers the question.
Turn off my audio. Uh, Thank you, Ross. No, no, that was really good. And a lot of themes came up during your interviews, et cetera. And you just mentioned a couple of them that I'm kind of a little bit more curious about, which is lacking psychological safety and no voice, no value. How exactly do these two differ? Maybe talk a little bit more about, but also they're in a relationship.
Yeah, so so David, I kind of touched on that, and I'll be a little more specific. So um, when we think about psychological safety, right? So psychological safety is the presence, right? It's the presence of safety in an environment that allows us to speak up, that allows us to take a risk. I need help, right? If you're not feeling safe, you're not going to ask for help. So when you're not asking for help, right, and you're in an so in the lacking psychological safety theme really really gets at that quiescent silence, which is I'm sitting in silence because I'm scared, right? I'm scared that you're going to judge me. So that's lacking psychological safety. The no voice, no value gets at this other element, which is a little different, but embedded in psychological safety, which is I'm speaking up, nobody's hearing me, and so I'm going silent. And in the psychological safety scale, the Edmondson scale, one of the questions is my voice is or my voice is valued by my team members, something like that. My voice is valued and heard among team, or my ideas and suggestions are valued by my team. So it's that idea of I feel valued enough to speak up. And so that's where that no voice, no value is, where I'm not feeling valued enough to speak up because I've been trying and nobody's listening. So I hope that helps.
Yeah, yeah. Thank you for elaborating on that. And we are at the 53, we're approaching the top of the hour. Once more, I found this very interesting. I really do appreciate you bringing together this mixed method approach to this question. With that said, unless there's any other questions from the audience, I'll ask you kind of like a final question. I don't know if it's really a question, but if what's the one thing you want people to take away from your presentation today? What's the
Yeah.
take-home point per se, right? If you
Yeah.
just remember one thing.
Yeah,
You can make it two if you have to, but yeah.
you know, I'd say the big take home message here is that, this is a pretty low tech issue. Psychological safety is created by leaders and team members who value relational connection, relational um, interest in one another, enough to then promote the sharing of that which is wonderful and great, I made a success, and that which is not so great, which is I need help, right? So we can really promote psychological safety in our workplaces by creating relational connections, by fostering those connections so that people will and can speak up when there is a challenge.
Oh, we go. One more question in. Perhaps we can kind of, and you can see this yourself. It's from
Oh,
Karina. It's fascinating research. You mentioned cognitive load. Are there any fMRI studies that provide insights into psychological safety in the workforce?
hi, Karina. That's a great question. It's interesting. I have not seen that, but I wouldn't be surprised if that's coming because there are actually a couple of silence researchers that are really looking into this cognitive load piece, and that those are cognitive scientists, and so I wouldn't be surprised if that comes soon. But I think there's definitely a place for biometric and other other, physiologic study of the presence of psychological safety.
Unless, do you have any final remarks, Ross?
No, I would just say thank you all so
Yeah.
much, and let's all go create psychological safety.
There's one more question.
Oh, okay.
And for those of you who were at the 57 mark, this is being recorded. So if any of you have to leave, feel free. And Roz, can you just answer the final question?
Yeah, so says absolutely agree with valued feeling from peers is great, but it doesn't amount to much when the next tier in the hierarchy doesn't want to hear your good ideas, which equates to change or extra work from them. From your qualitative collection, have any nurses been successful in making themselves heard up the hierarchy? Thank you for that. In my participants that were actively experiencing burnout, they were trying hard and they were not. And I think that that was a real struggle. The 5 participants that were not experiencing burnout talked about exactly this piece, which was going up the chain and advocating, right? Advocating for what they needed and what they wanted. And so that was autonomy in their practice management. That was, specific to things like they may have requested to narrow their scope of practice to see fewer patients, or I'm going to only do this, or I'm going to only do that, right? So really speaking clearly about what they needed and being willing to say goodbye if I don't get it. And I think that was the real piece, is that those participants really pushed hard, and 2 of the 5 actually left a job and found a new one. 3 of them were successful in staying in the same organization with renewed sense of well-being in the workplace after self-advocacy, going up the chain. But I think your point brings also just to clear is that hospital and clinic administrators are coming up in the burnout literature as being a major contributor. So that clinicians and health workers are not feeling supported by administration. And so I think that there's a lot that can and needs to be done within hospital and clinic administration to think about how they're leading and how they want to lead and how they want to support well-being in the workplace.
Okay. And with that, I think it's a wrap. Once more, thank you, Ross. It was very informative.